Okay, good.
Okay. So this is an interesting case. It's a patient who was sent to us from outside hospital. The clinical history, this is a 50-something-year-old woman who has chronic hep C, which was treated. Her viral load was next. She does not have cirrhosis. And then she had chest CT done for COVID. And then on the chest CT, they found liver masses. And these are the liver masses. And the workup, as part of the workup, the patient had MRI. And you can see just the entire liver is studded with the masses. Again, no cirrhosis, and she, her AFP is completely normal. All the tumor markers are normal. And aside from chronic hep C, she has no prior history. So I guess I'm gonna ask two important questions. One important question: do we apply LIRADS here?
That's a great question, Victoria. That always comes up with us. Like if they have hep C, but we don't see cirrhosis or known cirrhosis, then I don't think you can apply LIRADS.
Right. So according to strict rules, we should not apply LIRADS. There is a recent paper that kind of looked at it wasn't a large sample, but there was a mix of patients who were hep C without cirrhosis, some other like pre-cirrhotic conditions, and LIRADS did actually very well. But as of right now, we still can't use LIRADS unless we know the patient has cirrhosis. Now, in this patient, we knew the patient didn't have cirrhosis. I guess my second question is, what would you think these masses to be in this patient? And would you care of the fact that AFP is completely normal? Now, this is outside study, so I don't have DWI to show, I think. Yeah. So,
one thought I had was whenever I see multifocal enhancing washing out masses, if they don't have liver disease, I always try to look for a neuroendocrine primary or other, hypervascular primary.
Right. So, right. So in this patient, there's a differential, and HCC still is in differential, and so hypervascular mets are again. Now, appropriately, this patient was sent for biopsy, and this was all HCC. So the teaching point that I wanted to make is that, and this is something that comes up in discussions with sometimes with junior attendings, with residents, but AFP is normal. Does that sway you anyway? And it really doesn't. So this is a good example of how this liver is replaced primarily by tumor. It's all HCC, and AFP is completely normal. So high AFP helps, but low AFP really doesn't. And just something to keep in mind. So two teaching point: can apply LIRADS in this patient population, and don't use AFP as a negative kind of prediction.
Victoria, David has a question. He said it still could be HCC and adenoma, although low intrinsic T1 is unexpected. Do you think, say this patient hadn't had liver disease like hep C, and you were thinking about adenoma, do you feel the T1 helps you? Like if it's...
No, I don't think so. With this degree of involvement in such large masses, I think, let's say this was a 35-year-old woman on OCPs, I still would want to have a biopsy to confirm. It's true that it could have been an adenomas. But more importantly, I don't think that T1 helps you. I mean, for HCC, there are several papers that show that HCC can be anything on pre-contrast T1 and T2. It really is not predictive at all. They can be bright, they can be dark, they can be ISO. Adenomas as well, again, depends on the fat content and stuff. So I'm not aware of T1 being very helpful in this situation, like in helping to differentiate between the two.
Agree.